Hello, everyone, and welcome to our Pulmonary Insights from the LDS Natural History and Genetics of Food Allergy and Related Conditions NIH study with Dr. Andrew Lipton. I am Stacy Watson, the director of the Low East East Division of the Marfan Foundation. And in addition to holding this professional role, I am a member of this community living with LDS type 2. I am delighted to introduce you to Dr. Lipton, who is the medical director of the Pulmonary Function Lab at the National Heart, Lung, and Blood Institute. If you have questions for Dr. Lipton throughout the presentation, please use the Q&A option at the bottom of your screen rather than the chat so that it doesn't get lost. Thank you for joining us, and I will let Dr. Lipton take it away.
Great. All right. Good afternoon, everyone. Thank you, Stacy, and thank you for inviting me to participate in the conference. So I'm going to talk about the pulmonary aspects of Loeys-Dietz syndrome. We actually don't know a whole lot about pulmonary disease in LDS, and that's so I'm going to talk about why it may be relevant, and then go into some preliminary findings that we have from the cohort of LDS patients that we see at NIH, which have turned out to be a little bit interesting, and I think will point us in some directions for ongoing research. My slides are not advancing, so give me a second here. There we go. All right, so we'll just we'll give an overview of different types of respiratory disease and some aspects of lung function to kind of set the stage for what I'm going to talk about in our data. I'm also going to talk a little bit about lung function testing, and then I'll talk about why respiratory disease is important or should be or could be important in LDS. We know a little bit more about lung disease and Marfan, and so I'm going to talk a little bit about what we know there, and how that may be similar or a little bit different to LDS. And then we'll go through the findings that we have from our cohort, and then a little bit on what's next with our data. So, okay. So just a little bit of an overview of the mechanics of breathing. So when we breathe in, inspiration, that's an active process. The principal muscle of inspiration is the diaphragm. So the diaphragm contracts, and as it pulls down, the chest wall moves outward. And there are also some intercostal muscles in between the ribs, the external intercostals, that also get activated and help to elevate the ribs. And as the rib cage moves out and the diaphragm moves down, air enters the lungs and we breathe in. So for that to work efficiently, we need good diaphragm strength. We need a normal rib cage. We need a normal shaped spine so that the rib cage and the chest wall don't get distorted from a curve in the spine. And we need a good upper airway that doesn't collapse or obstruct the airflow. Expiration, on the other hand, is usually more of a passive process. During quiet breathing, the chest wall relaxes and recoils back to its resting state. And as that happens, the air moves out of the lungs and back up through the airway. But when we do forced expiration, we do need accessory muscles. And the principal ones are the abdominal muscles. So we contract our abdominal muscles. They force the abdominal contents inward, which push up on the diaphragm and help to force the air out. Okay. So when we think about breathing and the lungs, we can talk about different volumes and capacities. So the red curve here is somebody breathing, and we're watching that trace of air going in and out. So when we follow that along, just those normal short little waves at the beginning are what we call tidal breathing, and that's what we do normally when we're just taking quiet, comfortable breaths. If we breathe out on a regular breath and then we breathe out some more, that is called our expiratory reserve volume, that extra air that we can breathe out until we empty our lungs as far as we can. If conversely, when we are breathing tidally, we then take a deep breath in until we fill our lungs all the way to as far as we can, that is our inspiratory reserve volume. And we now fill the lungs to our total lung capacity. Okay, so all of that air that we can breathe, the inspiratory reserve volume plus the tidal volume plus the expiratory reserve volume, if we add all those together, we get our vital capacity. So the vital capacity is what we can breathe from a fully empty lung to a fully full lung. However, our lungs are never really fully empty. We can't blow all of the air out, and that's for a good reason. Just like when you try to inflate a balloon, if the balloon has no air in it whatsoever, that first part of the inflation is really difficult until you get the balloon stretched out a little bit. So our lungs would be that way too. So they maintain a little bit of air in them even when we blow all the way out. And what's left behind, that air is called the residual volume. So if we add the residual volume to the vital capacity, that gives us our total lung capacity. Okay, so vital capacity and total lung capacity are going to be important things that we're going to talk a little bit about when we talk about lung function testing. Now, when we talk about lung disease, we like to talk about it in kind of two basic categories: obstructive disease and restrictive disease. Obstruction involves airflow. So it generally means that there is more difficulty in moving air in or especially out of the lungs. Problems moving it in usually occur in the upper airway. So think about the throat and the neck and the upper part of the trachea. Whereas difficulty moving air out generally involves things lower down in the airways and as far down as the smaller airways. So with obstructive disease, it generally takes longer to empty the lungs. And in fact, in some cases, the airways may pinch off and close and air may become trapped in the lungs, and then the lungs, the residual volume increases. So some examples of obstructive disease are asthma, COPD, emphysema, and bronchiectasis, which is a scarring or injury to the larger airways. In restriction, we're talking about a decrease in the volume of air in the lungs. So an overall lesser value in virtually all of those different volumes, and especially in the total lung capacity. There's a variety of things that can alter the volume of the air in the lungs. So the classic one that people tend to think about is interstitial disease. So that's where there's a thickening of the connective tissues in the lungs, and they become stiffer and more elastic, and it's harder to get them to expand. So they tend to shrink down a bit, and the amount of air that can be held is less. But other things can also affect the volume of the lungs. So chest wall anomalies or scoliosis alter the shape of the chest and can lead to decreased volumes. Neuromuscular disease, if the muscles aren't effective in fully expanding the chest, then lung volumes will decrease. Pleural disease, the pleura is the outer covering of the lungs, and there are a variety of things that can happen to it that may affect the ability of the lungs to fully expand. And then other things that push up on the chest and prevent it from fully expanding. So extreme obesity or a very large abdominal mass or a big collection of fluid in the abdomen, all of those things can push up on the diaphragm and prevent it from fully pulling down and expanding the chest. Okay. So when we think about how those disease processes may affect lung function, when we measure lung function, we need to interpret it in some context. So we use reference equations that try to predict what normal lung function would be for an individual based on certain characteristics of them. So the principal ones that factor into these equations are age, sex, and height. Ancestry may be a factor, but we don't have a good way of accounting for that. And so just in the last few years, there's been a trend toward taking racial corrections out of the lung equations and using a global equation for everyone. And then, of course, disease affects the lung volumes and flows, and that's what we're trying to measure. We want to see, we want to try to normalize for all of these other demographic factors so that we can see what disease is doing to the lung function. Okay, so there are lots of different types of lung function testing. Common ones, and I will talk about these in a little bit more detail, are spirometry. We can give a bronchodilator, a medication to open the airways in someone whose airways appear to be closed. We can measure lung volumes in several different ways. We can measure diffusion capacity, which measures how readily gas is transferred from the air in the lungs into the blood. We can do a functional test, a 6-minute walk test, to see how far someone can walk and what happens to their breathing during that walk and to their oxygen levels. We can measure gas levels. And then there are some other tests where we can measure muscle strength, and we've done a few of these in our cohort. There are more extensive challenge type tests where we can put people on a treadmill or a bike and measure their lung and heart function together. We can do challenge testing where we give them a medication to try to trigger an asthma-like reaction in the lungs. Forced oscillometry is it's an old technique that is becoming more popular again in recent years, and we are also using this to look at our LDS cohorts. And it may give us other information about the elastic properties of the airways in the lungs. Exhaled nitric oxide is a test to look for a marker of inflammation, and we are using that in our LDS cohort. Talk about that in a minute. Okay, so spirometry is the most basic of lung function tests and the most common one. It's readily available even in many doctors' offices outside of hospitals. It is most effective in evaluating obstruction because it involves somebody taking a deep breath in and blowing out as hard as they can until their lungs are as empty as they can get them. And so since we can't measure the air that they can't blow out, we can't measure the residual volume, that means we can't know their total lung capacity. So a limitation of spirometry is that we can't really fully know about restrictive disease. Okay. But we can get some ideas about it from spirometry. Right. So the two basic things that we get from spirometry are the forced vital capacity. So that's the vital capacity, everything that someone can breathe in from total lung capacity down to residual volume. And we measure it with them blowing it out. If it is low, it may suggest that there's a restrictive process. We also measure the FEV1, the forced expiratory volume in 1 second, and that's how much air the person can blow out in the first second. That's a really good sensitive measure for obstruction. If there is obstruction, that number will usually be lower. It will take them longer to empty their lungs, so the amount they blow out in that 1 second will be decreased. And then another thing that we can do is we can look at the ratio of FEV1 to FEC. And in people with normal lungs or restrictive disease, that ratio is usually preserved because in restriction, everything gets smaller. The vital capacity gets smaller and the flows get proportionally smaller, so that ratio stays the same. If the ratio is low, that can also be a sign of obstruction. So another way of plotting spirometry is when we plot flow versus volume instead of volume versus time, like I just showed you. And then we can see different types of curves that are very characteristic. So a normal curve, the breathing out starts here at total lung capacity, it goes up real fast, and then it comes down in a kind of linear manner. And then the breathing in looks just kind of a symmetric semicircle. If there's obstruction, the flows are lower at any given lung volume. So this flow curve looks scooped out like that, a concave appearance. In restrictive lung disease, the shape looks normal, but everything is smaller. There's less volume, so the flows are lower proportionately. Okay. So we can measure lung volumes a few different ways. The most common way involves a box that looks like an old telephone booth where the patient breathes, and we can measure pressure changes that we can then backtrack to volume changes. Okay. All right. So when we get those numbers from the different tests, we can then try to put together a pattern that might suggest a different, whether there's obstructive or restrictive disease. So as we talked about, in restrictive disease, we're going to have a low vital capacity. If we measure the complete lung volume, the total lung capacity, we will also generally see that that will be decreased. Whereas the flows will generally be decreased somewhat proportionally, or they will be unchanged. And that ratio will generally be normal or maybe even slightly elevated. Conversely, in obstructive disease, usually the volume is normal, but the flows are decreased. And so the ratio is decreased, but our total lung capacity stays the same. If the obstruction is really severe, then the residual volume might be increased from air trapping. Okay. And then another test we can do is diffusion capacity, and that measures the ability of gas to transfer from the air sacs, the alveoli, into the blood cells in the capillaries that are adjacent to them in the lungs. If there's a barrier, if this area in between the alveoli and the capillaries becomes thicker for some reason, then diffusion may decrease. There are other reasons that we can see decrease in diffusion. That could also be something like emphysema. If the alveoli, if the air sacs get much bigger, there's not as many relatively as many blood cells surrounding them, blood vessels surrounding them. And so there's less opportunity for gas exchange. Okay, and that's the case in emphysema. Okay, and then the last test I'm going to mention is exhaled nitric oxide. So nitric oxide is a chemical that's produced by cells in our bodies. And we see increased levels in the breath associated with eosinophilic or allergic inflammation. And so this can be a useful marker for both allergy and for asthma. And it's can also be very sensitive in assessing the degree of control of asthma and the response to some asthma medications. Okay, so let's talk a little bit about LDS and relation to Marfan syndrome. So, you know, as I'm sure everyone knows, Marfan is caused by mutations in the fibrillin-1 gene. And this leads to defective elastic fibers, which certainly can affect the lungs. And it also seems to lead to increased levels of TGF-beta. In LDS, we now know there's at least 7 mutations, and they all seem to lead to dysregulation of TGF-beta signaling with variable effects. So there's some overlap here in the pathophysiology, and that there's TGF-beta involved in both disorders, but they're not quite the same. We know a little bit more about respiratory disease in Marfan because we've known about Marfan for a longer period of time, and it's a little more common. We do know from a variety of epidemiologic studies that chest wall anomalies are very common, probably around 2/3 to 70%. Scoliosis is common in at least half of people. COPD and emphysema, so dilated air sacs in the lungs with air trapping, leading to cystic lung disease, and also sometimes in infants, congenital lung malformations is prevalent in Marfan, though the exact degree of prevalence is not quite certain. Pneumothorax, or a ruptured lung, is also possible in Marfan, somewhere in the neighborhood of around 5 to 10%. And this is where one of those cysts actually ruptures and the air leaks out of the lung and the lung collapses. Asthma is possibly present in Marfan, but it's not really known to what degree it is there. But at least one study has shown that if you challenge people with something that tries to trigger an asthma response in the airways, that about half of patients with Marfan do have an abnormal responsiveness to that, suggesting that they're at risk for asthma. And then we also sometimes see respiratory muscle weakness, and then obstructive sleep apnea in about 1/3 of patients with Marfan. Okay. So how does that correlate with LDS? So chest wall anomalies are also common in LDS, depending on the type, somewhere between 1/3 and maybe as many as half of people with LDS may have a chest wall anomaly. Scoliosis similarly is quite common, with some cohorts suggesting as high as levels as high as 80%. Allergic sensitization and increased allergic inflammation, either in the form of eczema or allergic rhinitis or food allergies, is quite common, affecting about somewhere between a third and perhaps as high as half of patients with some types. Respiratory muscle weakness may be present, though probably not particularly common. There's a variety of upper airway anomalies that may be present. So the bifid uvula and or cleft palate, affecting up to a third of people with LDS. And then also some alterations in the shape of some of the facial bones and facial structures. So malar hypoplasia, a flattening of the cheekbones is common, probably more than half of people, and in some studies as much as 100% if you look carefully. Micrognathia or retrognathia is either a small or kind of posterior positioned jawbone, and that can be somewhere between 10 and 50%. And then also enlarged central blood vessels may potentially play a role in breathing disorders. And if there is abnormal connective tissue, that may also lead to problems in the lungs. Okay, so how do these different attributes factor into respiratory disease? So the chest wall anomalies and the scoliosis can lead to restrictive disease and occasionally obstructive disease if there's enough twisting of the chest that the airways become twisted or compressed. That will lead to obstruction, but generally we think about restriction with those two types of processes. The allergic sensitization can predispose to asthma, and so we believe that asthma is increased in prevalence in people with LDS. Respiratory muscle weakness will lead to respiratory insufficiency, so inability to achieve good gas exchange. The upper airway anomalies predispose to obstructive sleep apnea. And we'll talk about that in a little more detail. And then the enlarged blood vessels, if there is for example, a significantly enlarged pulmonary artery that could squeeze on on a large airway that's adjacent to it. So one of the main bronchi that goes into, say, the entire left lung could be squeezed by that large pulmonary artery. And there's at least one case report of an infant with that particular problem. And then abnormal connective tissues, which is probably more prevalent in Marfan, can lead to those things like pneumothorax, bronchiectasis, those are injured large airways, emphysema, and ultimately altered gas exchange. Okay, so the chest wall anomalies that we're talking about are essentially pectus carinatum and pectus excavatum. So pectus carinatum is an outward deviation of the sternum and the anterior ribs, whereas pectus excavatum is an inward deviation of the sternum and anterior ribs. These usually get worse during puberty. They are, for the most part, asymptomatic. But in recent years, we've learned that with really either severe deformities or asymmetry, where one side is affected more than the other, and often that occurs in combination with scoliosis, that exertional symptoms are quite possible. And people may get very short of breath when they push themselves. And that can lead to significant issues with quality of life. The treatment for pectus deformities is now almost universally via a procedure called the Nuss rod, which has been around for about 25 years now. And the primary indication for surgery is for cosmetic reasons, which is a very valid reason to do the repair. It is usually deferred until most growth has occurred. If you do it too early before puberty, generally it will need to be redone at a later point. And the cosmetic outcomes from this procedure have generally been very good. But there's far more limited data on any sort of benefit in terms of lung function and breathing. We do think it probably stabilizes any further worsening. And there are some data that suggest that there might be a benefit on alleviating some exertional symptoms, but we need better functional studies such as exercise tests to really further elucidate the benefit. We generally don't see a big change in any of the numbers in lung function after repair. And this is just showing the Nuss rod, which is a curved rod placed at the lower end of the rib cage, and then rotated outward to push the rib cage out. That rod's left in for about 2 to 3 years, and then removed after the rib cage is remodeled. Okay, and then scoliosis is the other significant skeletal anomaly that can affect respiration. So obviously, if you have a significant curve, especially in the thoracic spine, the chest is going to become distorted. Airways will become twisted, and it may be difficult to fully empty the lungs, or it may be difficult to fully inflate them due to the curve. Okay. And the degree of curvature, the worse the curve, the more effect it can have on respiration. So mild curves don't really usually cause any problem, but more significant curves lead to decreased lung volume, restrictive disease, exertional symptoms, and eventually, if severe enough, respiratory failure, as the lungs can't meet the needs of the individual. Okay. Treatment for scoliosis generally, if it's mild, may involve bracing, but more severe will involve placement of some type of rods to help stabilize and straighten the spine. Okay, and then treatment. So for allergic disease, we have medications such as antihistamines, avoidance of allergens, desensitization, and EpiPens. For asthma, the mainstay of chronic treatment is going to be inhaled steroids. We have a lot of new biologic agents for more recalcitrant asthma. And then we use drugs to try to relax the muscles in the airways, particularly during attacks, but also we have long-acting versions of these. And there are some specific concerns with both Marfan and LDS in terms of these medications, because the most commonly used ones and the most effective ones are beta agonists. And beta agonists also increase the contractility of the heart and cardiac output, and they also can cause tightening of blood vessels. And so these could potentially be an issue in people who have aortic root problems. And so we want to be a little bit judicious in somebody with LDS when using the beta agonists. Also, if people are being treated with beta blockers because of any of their cardiovascular manifestations, those can actually make asthma worse because they are blocking the relaxation of the airway muscles. So we also have to think about that and be cautious and perhaps choose other agents in people with asthma if they need to be on something to alter their cardiac output. Okay. Treatment for enlarged blood vessels that are compressing airways would be surgical. Treatment for pneumothorax is an emergency that involves a chest tube, and then ultimately usually surgical resection of any blebs that are rupturing. There have been a few case reports of people with pneumothorax and LDS, but it doesn't seem to be very common. Okay, so what have we found in our cohort? We've been able to analyze so far around 80 patients who've had pulmonary function testing in the NIH Clinical Center. The mean age for our cohort is around 30 years, so we have a pretty young cohort. But the range is actually from 6 years up to 71 years. About a third of the cohort is male and the other 2/3 female. And so what have we found with the extensive lung function testing that we've done? So dysynapsis is a word I haven't used yet, and that is a pattern that's somewhat nonspecific. That's where that FEV1 FVC ratio is low. but all of the other numbers are normal. So when the FEV1 is normal and the vital capacity is normal, so we don't see clear obstruction, we don't see any restriction, but the ratio is just a little decreased. In some cases, that may be just a disconnect in growth between the airways and the lungs, so that the airways are relatively a little bit small for the lungs that they're connected to. That could happen during growth, or in any individual, they might just have relatively small airways. But it also may be an early sign of obstruction. And there are many studies that link dysynapsis as a risk factor for later development of emphysema. So it may turn out to be more important for some people, and it may be an early manifestation of obstruction. So we've seen 10% of our cohort with dysynapsis. We've seen about a quarter of our cohort with obstruction. And if we lump those two together, to taking them both to be signs of obstruction, we have about 37% of the cohort with some evidence of obstruction. And that's a bit of a surprise, because the most obvious reason for a respiratory problem in the people that we've seen has been scoliosis and pectus excavatum or carinatum. And we would generally expect restriction from that. So the fact that we're seeing a lot of obstruction is interesting, and is a topic for future work. With respect to restriction, only about 14% of the cohort have clear restriction. So it is there, but it's not particularly common. And then we have a handful of patients that have a mixed process where they have some evidence of obstruction and restriction. And often that is seen in very severe scoliosis. Okay. Diffusion problems. So a low diffusion capacity, meaning that it's more difficult to move oxygen from the air to the blood. About a quarter of our cohort have a low DLCO. And that also is something that is going to need to be further explored. Bronchodilator response. So about 17% responded to a bronchodilator, albuterol, when given. So that's a suggestion that there is some twitchiness of the airways, either frank asthma or predisposition to asthma. And then elevated nitric oxide, that marker of allergic inflammation, quite common, about a third of the patients with evidence of airway inflammation. Okay. We also did some tests of muscle strength. So MIP and MEP, maximal inspiratory pressure and maximal expiratory pressure. These are simple tests of somebody just breathing into a tube as hard as they can against a pressure transducer, or sucking in as hard as they can against the pressure transducer. And we found some low levels of muscle strength decreases, and it seems to be kind of equally split between expiratory muscles and inspiratory muscles. But when you add all of the total together, close to half of the patients had some evidence of decreased muscle strength. So that is also something that we will probably need to look a little bit further into. Now, these particular tests are very effort dependent, so sometimes the numbers are a little higher than what we're truly saying. And then I'm going to talk just for a couple minutes about obstructive sleep apnea. So obstructive sleep apnea is an intermittent, partial, or complete cessation of inspiratory airflow during sleep, despite the individual continuing to try to breathe in. And this can lead to decreases in oxygen saturation. It can lead to an arousal for a very brief period where the brain senses that there's a problem and wakes the person up to take a better breath. And ultimately, those two things both can lead to very disrupted sleep. Risk factors for sleep apnea include low muscle tone, nasal or pharyngeal obstruction, craniofacial anatomic variants, including things like micronathia. Obesity is a big risk factor, and family history is also a risk factor. Okay. So the diagram here is just to illustrate that the most important part of the upper airway in terms of sleep-related breathing occurs in the posterior pharynx. And so at the back here, where the soft palate and the hard palate come together and the tongue pushes up in that area, and the adenoids are right behind there. And so you can see that any narrowing in this area is going to lead to altered airflow and a risk for sleep apnea. And I'll come back and talk about that in a second with respect to LDS. So what are the consequences of obstructive sleep apnea? Why does it matter beyond loud snoring? Well, it can lead to daytime somnolence. This can lead in kids to difficulty in school, in adults, poor work performance or motor vehicle accidents. It can put a strain on the heart, which can lead to pulmonary or systemic hypertension. Ultimately, heart disease and stroke are increased, cognitive and learning impairment. There's also an increased risk for type 2 diabetes. And it also affects anyone else in bed with the individual with sleep apnea because they don't get good sleep. They get disrupted sleep. Diagnosis is generally through overnight polysomnography. This can either be in a dedicated sleep laboratory or oftentimes nowadays in the patient's own home. So there are multiple reasons in people with LDS why they might be predisposed to sleep apnea. We know that cleft palate and bifid uvula are both common and suggest that there are some differences in the anatomy in the posterior pharynx. We also know that it's common to have differences in facial bone structure, so the malar bones and the mandible, the chin. And as they are flattened out or smaller or more posteriorly positioned, then the airway becomes a bit compromised and sleep apnea is more likely. Okay. With respect to prevalence, sleep apnea in the U.S. is quite common, perhaps as high as 30% in men, a little less common in women, around 10 to 15%. We know that in Marfan syndrome, it's around 35%, so a little higher than the general population. We really have no idea in LDS how prevalent sleep apnea is, but we have noticed in our cohort that many of our patients complain of symptoms of sleep disordered breathing, such as loud snoring. And a number of them have already been diagnosed with sleep apnea prior to us seeing them. So we recently changed the protocol for our cohort, and we are now trying to obtain overnight sleep studies in most people when they come to visit the NIH, so that we can get a better idea of how big of a problem this is. Treatment for sleep apnea, CPAP and BiPAP are methods of delivering positive pressure to use the pressure to push the airway open. Sometimes surgery, particularly in kids, large tonsils and adenoids can be a problem, and generally that is pretty effective in people that don't have other underlying reasons for their sleep apnea. But if they have alterations in facial anatomy, then things directed at that may be more beneficial. So uvulopalatopharyngoplasty is a surgery of the palate. Oral appliances help to position the mandible in a different way. It's something that you wear in your mouth. And there is surgery to advance the mandible if necessary. Hypoglossal nerve stimulators are a relatively new technology, and certainly no data on that in LDS patients. Okay. So now that we have some preliminary data on pulmonary function, where do we go from here? So we're going to try to increase the data by combining some of the pulmonary function testing from the cohort at Johns Hopkins with ours. And then the next step is really to associate the pulmonary function test anomalies that we're seeing with clinical manifestations. So are we seeing these primarily in people with chest wall anomalies or scoliosis? How are they related to the particular mutation and type of LDS? And what other things correlate with the findings? We're going to try to quantify the severity of the PFT abnormalities. Most of what we're seeing is fairly mild, but we're going to work with the numbers a bit to better quantify that. And then sleep disordered breathing is an open-ended question that needs to be explored further. So thank you, and I am happy to answer questions.
Takes a second for me to come back from
Yeah.
the backstage
Thanks
area.
for warning me about that.
No, thank you so much. It's so interesting to really hear kind of what we're already learning from this study. And there are a number of people who are joining us today who have participated and have just stated how great of and positive of an experience it was for them to participate. So in the chat, we put information about studies that we know of that are seeking participants from the LDS population. So take a look at that if that's something that you might be interested in. I am going to turn our attention to questions that came through the Q&A. And Anissa asks, are right-left shunts associated with LDS? If so, where do these shunts originate in the body and what is the treatment? I'm not sure that I understand the question. I'm hoping that you do.
So a right to left shunt is so the right side of the heart pumps blood to the lungs to get oxygenated. And then the blood comes back to the left side of the heart, which then pumps it out to the rest of the body to use that oxygen. A shunt is when blood short circuits the path it's supposed to follow. So a right to left shunt is when blood coming out of the right side of the heart that is supposed to go out to the capillaries in the lungs and pick up oxygen instead crosses right back over to the left side of the heart and doesn't pick up oxygen in the process. And so that can lead to low oxygen levels in the blood because not all of the blood is going where it should to get the oxygen. So right to left shunts can occur with a congenital heart problem. So if you have a hole between two chambers in your heart, the blood can short circuit right through the heart directly. But in this case, I think the question is more geared toward what happens if there's abnormal blood vessels in the lungs that are allowing shunting to occur in the lungs. So that can happen either through dilated blood vessels in the lungs, where the blood is moving through so fast through these extra large vessels that it doesn't have the time and the ability to pick up the oxygen. Or it can happen through abnormal connections of blood vessels in the lungs. Those are called arteriovenous malformations. So since arterial changes are the most obvious and most important manifestation of LDS, certainly one question is are there more issues with right to left shunting and abnormal vessels in the lungs? And so I think it's a really good question, and I don't know the answer to it, and I don't know that we know much about it, but that is one particular explanation for finding a low diffusion capacity in someone. And so since we found a low diffusion capacity in about a quarter of people, and we don't really have necessarily a good explanation for that because we don't think they have interstitial lung disease, I think that is a question that we need to look at a little more thoroughly. And perhaps there are right to left shunts occurring in some people that we're unaware of.
Thank you. This should be an easy question. Karen asks, what kind of doctor can diagnose an obstruction that is caused by facial features, craniofacial features?
Mm-hmm. So the doctors that generally deal with that, both pulmonologists and otolaryngologists, ear, nose, and throat doctors, are well versed in upper airway obstruction. Sleep disordered breathing. So sleep studies are the best way to really fully pick up that kind of obstruction. And sleep study people, physicians specializing in sleep medicine actually can come from a variety of backgrounds. So some only do sleep medicine. Others come from a pulmonology background. Others come from an ENT background. Others come from a neurology or even a psychiatry background. But many of these different pathways can kind of all lead into sleep medicine. So generally, I would start with your primary doctor because sleep apnea is so common that all primary care physicians, both pediatric and adult, should be familiar with a lot of the hallmarks of sleep apnea and upper airway problems, and then they would be in tune to refer you on to an ENT or a pulmonologist or a sleep medicine specialist as appropriate.
Thank you. This is a very interesting question from Mary. Is there any imaging or testing that can be done to see if CPAP or surgery is a better option for treating obstructive sleep apnea?
Um, that's a good question. I think the first part is an exam. So, an ENT and a dentist or an oral surgeon who are familiar with sleep apnea and treat it can actually do some pretty good assessments just on exam in terms of deciding whether there might be a particular surgical treatment or an oral appliance that might benefit a particular individual. There are some studies looking at different forms of CT scan. So CT scan is a good way to look at the facial bones and the mandible. And so certainly a CT scan can help point to, you can also see the soft tissues. So it can help. But one of the problems with that, one of the limitations to that is that sleep apnea is a dynamic problem. So your airway will be open when you breathe out, but it will be obstructed when you breathe in because of the differences in pressure change. And so if you do imaging like a standard CT scan, you're not going to necessarily capture the airway while, to see those movements and changes with the respiratory cycle. So you may find obvious changes in some of the bone structures there that might suggest an amenability to surgery, but dynamic studies are going to be a better way. And so they're putting a camera, a scope in there and watching during breathing. There are people that do sleep endoscopy, sleep laryngoscopy, where they'll actually put a camera in there while someone is sleeping, or usually they're given a sedative to simulate sleep, to see what the airway does during relaxation. There have been a lot of research studies looking at dynamic CT and dynamic MRI, but those are not readily available techniques.
Thank you. Lauren asks, how does costochondritis and chestal wall pain play into LDS and pulmonary restriction?
So I don't know. So costochondritis is inflammation of the cartilage that connects the ribs to the sternum, and costochondritis, it occurs usually in response to some kind of injury, and when you have inflammation in those areas, it becomes difficult to breathe because as the rib cage moves during breathing, those cartilages get stressed, and any inflammation around them is painful. And so I don't know that there's a specific predisposition to that in LDS, but there certainly might be due to changes in connective tissue. Anyone who is affected by costochondritis, they are often going to have difficulty taking a deep breath, because as they try to fully inflate their lungs and they stress those junctions between the ribs and the sternum, it's going to be painful. And so their natural inclination is going to be to stop breathing, or to breathe shallowly. And if we breathe shallowly, then we're not using our lungs to their full capacity. That shouldn't, if it's a temporary problem, lead to any sort of permanent alteration in lung volume. So if the costochondritis is treated or it resolves on its own, and then the person's able to resume taking deep breaths, they shouldn't have permanently lost any lung function. I suppose if it is a chronic problem that is difficult to treat and leads to years of difficulty in breathing, eventually the lungs may start to essentially kind of shrink. That we may get atelectasis, which is collapse of parts of the lungs, and they may not be able to be easily reinflated back to their full volume.
Thank you. There's a couple of questions related to allergic disease and treatment. So Dana asked, what are your thoughts on treatments for allergic disease for LDS patients, such as OIT, Xolair, etc.? And then there's kind of a follow-up from another person about your opinions with patients who have LDS and anaphylaxis, and then the recurrent use of epi, which I imagine this question is being asked because epinephrine raises the heart rate and puts stress
Yeah,
on the vascular
yeah,
system.
yeah. So I agree. I think, you use an EpiPen to save your life. So when you're having a severe allergic reaction that may be or may be progressing quickly to anaphylaxis, which is essentially a form of shock, where your blood vessels become so dilated that you don't your blood pressure drops precipitously and you don't get enough blood to your organs. um, epinephrine EpiPens cause the vessels to tighten and increase your blood pressure and get you through that until the process is reversed. It is certainly a potential risk factor in someone with LDS. But if you need an EpiPen and you don't use it, you have a high risk of dying from the anaphylactic reaction. So you kind of have to do what you have to do. But the ideal situation would be to come back to the first part of the question, which is how can you prevent from getting into that situation in the first place? Um, I am not an allergist, and I'm by no means an expert, and certainly in oral therapy for allergy, the OIT, and some of the newer biologic drugs like Xolair have been very beneficial, both for really recalcitrant allergy, atopic dermatitis, asthma. So when standard things like antihistamines and inhaled or nasal steroids are not doing the job, some of these biologic agents have really proven to be both very useful, very successful, and for the most part, very safe. So I think it's been an exciting world in asthma and severe allergy in the last 5 to 10 years with the development of all these biologic agents that are now on the market. And so I think that's, certainly goes a long way toward hopefully keeping people out of anaphylaxis.
Thank you. We are really close to the end of our time, so I'm just going to prioritize. Dr. Guerrero, Dr. Tony Guerrero is on. He's presenting later today. He's going to be talking about epinephrine use in LDS for food allergy in the GI Talk at 6. So thank you for
Perfect.
that's perfect. Okay. Just a couple more questions I think that we can answer. Are blebs common or problematic in people with LDS?
Yeah. So I don't think we know the answer to that. I have not seen a lot of data that suggests that they are. We know that they are an issue in Marfan, but I have not yet seen anything that really suggests that they are a problem in LDS. And actually, I just reviewed the literature, and there's really like one or two single case reports of people developing a spontaneous pneumothorax with LDS. So I wouldn't say that that it's not there. It certainly is possible that it is an issue, but so far I have not seen any data that really suggests that it is as common in LDS as it is in Marfan. And so right now I don't think there's a huge risk there, but it is certainly a possibility.
Thank you. Do you know if people with LDS are at a higher risk for flash pulmonary edema?
Um, I don't know the answer to that. I have not seen anything suggesting that. That would occur if blood vessels kind of suddenly dilated and allowed too much blood into the lungs, and then that led to fluid kind of leaking out of the blood vessels into the air spaces of the lungs. That's what pulmonary edema is. So certainly in someone who has abnormal blood vessels, that could be a problem, but I have not seen anything that suggests that it is a problem in LDS.
Thank you. And then this is the last question that we have time for, and that's actually in our Q&A. Is there any research on LDS and pulmonary embolism?
Not that I'm aware of. I have not seen anything linking those two.
Great, thank you. Just on behalf of the foundation and the community, I want to say thank you so much for your time and your insights and your participation in our conference this year. We hope to see more of you. And also to anybody who is watching, if you have specific questions that kind of have come up as you've been listening to this conversation, please take advantage of the Help Center, marfan.org/ask or louisedietz.org/ask. And we hope to see you all at another session later today and throughout the week. Again, thank you so much, Dr. Lipton. We really appreciate it.
Thank you. Bye.